Well, thanks, Dr. Wexner, for the invitation. We're going to talk about one of my favorite topics, which is transanal excision. I have no disclosures. The trends of local excision, as you can see in this study gathered from data from the National Cancer Database, showed over the years from 1999 to 2003 an increasing trend for local excision of T1 and T2 cancers, and sort of paradoxically there was a decreasing survival rates during the same period for these patients with local excision for the stage-by-stage cancer. So what we have to ask ourselves when we think about local excision is just because you can do something, it doesn't mean you should do it. And there's all sorts of factors that would limit the utility of transanal excision in patients with rectal cancer. Most importantly, the tumor, factors related specifically to the tumor. There's factors related to the patient and also to the technology, and we'll talk a little bit later about some of the new platforms for transanal excision. So I'm going to tackle the should question first. Should you do it? As we heard extensively in the last session, there's a lot of options for the treatment of rectal cancer. We can do a total mesorectal excision, a standard transanal excision, or a transanal, an advanced, we'll call it transanal excision with one of the platforms. And my bias is to use the TEM instrumentation because that's what I'm familiar with and that's what I sort of grew up with. This is how I feel about standard transanal excision. I could never get great exposure. I could never see too well. And when I started doing TEM, because Dr. Wexner made me, I quickly realized how much better the view was and how much more I liked performing local excisions. And there's all sorts of data in the literature to suggest and support the fact that at least with TEM surgery compared to standard transanal excision, the results are superior with respect to quality of the specimen and local recurrences. So if once we decide that we're going to do a local excision, or if we're going to do a local excision, it would be with one of the advanced platforms, and in my hands that would be with TEM surgery. But really to make that decision, we have to decide the oncologic aggressiveness of the tumor. And really this falls into predicting nodal micrometastases, which you heard in the first session today, that's really difficult. Some other things that we can use are tumor morphology, we can use radiologic evaluation and also histologic examination, all to decide if it's really oncologically sound to proceed with a local excision. And we're going to touch on each of these somewhat. First of all, tumor morphology. Let us not forget our greatest examining tool is the digital rectal examination. If you can feel the tumor, we can have a lot of clues to the behavior of that tumor, if it's firm, if it's ulcerated, if it's fixed, and also assess the size of the lesion and the distance from the dentate line. With respect to rectal cancer staging, we heard this from Dr. Pilati, but lymph node involvement is really hard to predict micrometastatic disease with radiographic imaging, and you can see here between ultrasound, CT, and MR the range of sensitivity and specificity for predicting lymph node involvement. None of them are perfect. If we look at 2D versus 3D ultrasound versus CAT scan, there may be some benefit with the 3D ultrasound. And if we look at a recent meta-analysis of endorectal ultrasound, and this would be 2D ultrasound, there were 35 studies with almost 3,000 patients, and in predicting lymph node status, we had about a 75% sensitivity and specificity, so 25% still challenging. So what about MRI? We heard a lot about MRI again, and we can't really use size alone as a parameter because, as we saw from Dr. Burho's talk, some of these lymph nodes are less than 5 millimeters. So if we combine size with border characteristics, irregular borders, or heterogeneous signal intensity, we can increase the sensitivity and specificity with MRI diagnosis of lymph nodes. Overall, in a recent meta-analysis for MRI, you can see here again, we're still in the 70% range for sensitivity and specificity for evaluating lymph node metastases. So there's no radiologic tool that will give us a guarantee of predicting micrometastatic disease in the lymph nodes. So what about histology? Well, we all know that vascular invasion, lymphatic invasion, mucin production, and differentiation have been historically discussed as poor pathologic predictors and poor prognostic indicators. So some of the newer kids on the block are the tumor budding and depth of submucosal invasion, and these may not be routinely reported in your pathology specimens, but we should look for these when trying to make decisions about whether a local excision is going to be adequate oncologically. And this is just an example of tumor budding where you have micrometastatic deposits at the growth border of the tumor, and it's not always routinely reported in your pathologic specimens, but probably should be. And if we look at submucosal invasion for T1 cancers, the depth of submucosal invasion can also be very important, but not routinely reported in pathologic specimens. So we found that the superficial SM1 or intermediate SM2 or deep invasion into the submucosa, poor features and poor behavior was associated with SM3 disease, lower third lesions, and the presence of lymphovascular invasion. So all, sort of gathering up support to develop ideas about which tumors are going to be more aggressive than others when we're trying to stratify these the lower stage tumors, the T1s and T2s now. So tumor factors, and looking at all of these 400 patients with distal rectal cancers, of the 88 T2 patients that underwent a more formal excision, 19% of them had lymph node metastases, and the predictive indicators were perineural invasion and vascular invasion for predicting micrometastatic disease in these lymph nodes. So there's not going to be one simple answer to a specific test that's going to give you the go to settle or be satisfied with a local excision versus a more radical excision. So we have to look at all factors put together. What about the patient? I do TEM surgery, as I told you, and with TEM surgery, you have to position the patient in all sorts of different positions, either in the prone, left, or right lateral decubitus position, or the lithotomy position, depending on the location of the tumor, because we like with this fixed platform for the tumor to be at the 6 o'clock position when we're operating. Well, if this person walks into your office, you should be thinking carefully about how you're going to deal with patient positioning. And typically, these are the patients that get sent to me by some of my partners who would rather not do an anterior resection, and they wind up in my office, and I have to figure out how we're going to position them prone, and the anesthesiologist usually doesn't appreciate you. So just, again, something to think about when you're contemplating a local excision. So what about patients who have anal stenosis? This is the operating proctoscope that I use. It's a 4-centimeter diameter proctoscope. Patients who have anal stenosis, patients who have fecal incontinence may not do well. Certainly patients with anal stenosis, you're not going to be able to introduce this proctoscope. So again, things to think about when you're planning. Incontinence, I think it's important to document continence status on all of these patients preoperatively, but if you think about the continence of a patient after your TEM surgery versus a coloanal anastomosis, I would usually favor the local excision if all the other parameters were in check. So what about the technical limits? There's instrumentation, there's issues with reach, and there's a learning curve. The instrumentation slide used to be a lot more simple a few years ago, and I borrowed this slide from one of my colleagues because she had all three of the potential platforms that we can use. As I said, I do standard TEM surgery, which is in the middle, the Richard Wolf platform. It has the operating proctoscope. There's a suction insufflator that provides a balanced pressure in the rectum while you're operating. The Karl Storz TEO instrumentation set is also involves the use of an operating proctoscope, but more standard laparoscopic equipment. And there are some specialized instruments now with the set to allow for more ease of operating through the proctoscope. And then there's the TAMAS instruments, which I don't use myself, but these are becoming rapidly popular because of the cost and ease of getting them in your hands in the hospital, as opposed to making a capital investment in one of the other sets. But TAMIS is really an anal retractor. There is no operating proctoscope, and I'll show you in the next slide some differences in utility of each of the systems. So we have to remember the rectal anatomy, and in the rectal anatomy we have folds and turns, and if we're using a TAMIS system, we can have some significant challenges getting around turns and going to the higher lesions, especially early on in your experience. Again, things to think about in your operative planning. The two sets that have an operating proctoscope will allow you to navigate up to the lesion and provide retraction of the rectal wall so that you can be working with your instruments right at the lesion rather than introducing your instruments through the anus with no rectal retraction whatsoever. But I think that for lesions lower down, that the TAMIS system would be adequate, especially if you're not trying to get around any folds. But you just need to understand the limits of the instrumentation that you're using. What about the learning curve? A lot of, TEM was introduced in 1983 and was really slow to take off. And I think the reason was the perceived difficulty. This study showed decreased complications after the first 50 patients. When we looked at our experience at the clinic, this is a Kusum curve, and if anyone's familiar with the statistics of it, when the curve gets flat is when there's decreased variability within the system that you're measuring and indicating that you've surmounted the learning curve, and that really happened after the first 8 cases. So the learning curve may not be as steep as we think. And if we look at the results quickly for TEM surgery, and these are all TEM and not using the other platforms, but I think there's not going to be any debate whatsoever about using TEM for benign disease. As I showed you earlier, there's a lot of data to show that the results are superior to standard transanal excision with respect to specimen fragmentation and specimen handling and margins, and you can see here very favorable local recurrence rates for benign disease. T1 lesions, similar results here. These are largely single surgeon retrospective reviews, but you can see very favorable results for T1 cancers. And what about for T2 cancers? This is the Lizokis data with 135 patients, T1 and T2 in this series, but all of the T2s had radiation therapy with significant follow-up, and there were no statistical differences in the disease-free survival or the recurrence rates. And if we look at the most recent update on his series of T2 cancers, this is 50 patients in undergoing TEM surgery after radiation and 50 patients undergoing a laparoscopic anterior resection. And it should be understood when you look at this data that it's not just a disc excision of the rectal wall here. He really does an extended lymph node dissection out to the mesorectal fascia so that he refers to this as a truncated pyramid, if you can imagine what the specimen looks like. So not just taking the rectal wall, but taking the mesorectum underneath. All patients had neoadjuvant therapy with almost 10-year follow-up here, and with no statistically significant differences in disease-free survival, distant Mets or local or distant failure. So showing some promising long-term results in a prospective randomized trial. Pushing the envelope, extended resections. I know that some people are using different platforms to perform TEM-assisted TME. This is where the initials become a little bit confusing. And is this a good platform for notes? This would be, certainly pushing the envelope and not the standard of care in the treatment of rectal cancer at this point. So what are the limits of transanal excision? With careful patient selection, appropriate radiologic staging, thorough pathologic evaluation, and mastery of technique, I think that any benign lesion should be approachable with transanal excision with one of the platforms that I've described. Many T1 cancers, looking at the pathologic features as well, and I think that the data for T2 cancers with radiation therapy, while there are some long-term series coming out now with favorable results, I think there's some studies that we're still waiting for the results here in this country. Thank you very much. 10 seconds to spare.